Okay. In this lecture, we're going to talk about how to take care of a patient who has been burned. This is a really challenging area of nursing. I've had several patients, students decide to go into burn nursing, and they have absolutely loved it, done well. They've worked at the burn units down at Receiving Hospital. It's very challenging. There's a high rate of burnout. No pun intended, but it is. It's a burn. The burn nurses get burned out really easily because it's really emotionally challenging. The units where the burn nurses work have to be hot. It's very warm. So like when I have been working in hospitals, if you ever have to work in a unit that is right above the burn unit, your feet are always warm because it's so hot in the burn units, because hypothermia is a problem because they lose so much skin. But at the same time, the nurses have to be all covered and, with masks on to maintain sterility, so there's not a lot of bacteria floating around, and they're working for hours to just change dressings. So it's physically difficult. It's very intellectually challenging because you're constantly following fluid and electrolyte shifts. So and the patient's in constant pain. It hurts really bad to have a burn. So we're going to talk a little bit about that. I don't think this book does a great job with showing some of the different kinds of burns. I think the pictures of some of the different burns help you understand the differences between, like, what's an electrical burn, a thermal burn, a chemical burn, just like a regular burn. So I might throw some of those up on Blackboard just so you can see that. And I also think that it's not real clear about the different phases of the burns, but we'll talk about that as we go through this chapter. Okay. So the first thing I guess I want to talk about, obviously prevention, it's a safety issue. It really, now I'm on page 1807, the severity and the depth of the burn and the age of the victim have an awful lot to do with the recovery of your patient. The very old and the very young do worse than people between the ages of like 5 and 65. And location of the burn also matters. I want to direct you to table 62.1. In the past, burns used to be categorized as first, second, and third degree burns. Now they're categorized as superficial, partial thickness, full thickness, and full thickness, including muscle and bone. And if you go back to chapter 60 and that first diagram that shows the breakdown of the skin, that's what it's based on. So, lots of people still use first, second, and third degree, but the technical terms now are partial, superficial, partial thickness, full thickness, and then full thickness to the bones, which is also called fourth degree. The first thing that you need to know about figuring out how bad the burn is you need to figure out the percentage of the total body surface area that has been damaged. And there's a couple different ways to do this. The most common is the rule of nines. You do need to be familiar with this. And the reason I tell you that is because I've seen a couple blueprints of the NCLEX, and they are, one, asking you to know what the rule of nines are, and then in some cases are asking you to calculate it. So I don't think your book does a great job showing you how to do this. I will show you in class, and I'll put it up on Blackboard too, how to really figure out the rule of nines. I'm going to go over that in a second. And then, because the rule of nines is kind of broad, and so the Lund-Browder method is another method of figuring out what percentage of body has been burned and how bad it is. And then there's a Palmer method. Most people just really quickly do the rule of nines, and I think, did I see somewhere in your book where it shows you how to calculate that? I will figure that out. I thought it was in here. If not, I do have it. But you basically you need to know, well, I'll go over that later. I'll figure that out. I'm sure I have it somewhere in here. Let's move on. I'll tell you about that later. Okay, so this figure 62-3, see how that little guy is divided up into anything that can be divided by 9? That's why it's called the rule of 9s. The most important is the head and neck area. The whole head and neck area, even though it's a small portion of the body, it gets 9%, just the head, because it's really substantial if you have a head and neck burn because of all the swelling that can occur, and then that can cause airway problems. That's why that one's so important. And then in the chest, the chest and abdomen gets 18%, and then the posterior gets 18%. Here's the thing about electrical burns. Electrical burns will come in through you know, any kind of an electrical source, and it will have a point of entry and then a point of exit, and it often will cause this thing called an iceberg effect, where it will come in one area, and that area can be really small. It will travel through the body, and then there will also be an exit wound, but they can often wreak considerable havoc as it goes through the body. So even though the point of entry might be small, there could be significant damage inside the body, depending on what organs it hits on the way down. Lightning strikes, DTE workers, you know, a couple years ago, right in this area, we had a big ice storm, and there were some lines down, and some like middle school kids were walking to school, and this line was down, and one of the kids went and grabbed that wire. And one thing with the electrical burns is when you grab the wire, your muscles and ligaments immediately contract, and they won't release, and so you just continue to get burned. The other thing you need to teach, if you're ever in the community or teaching people, or for your own safety, is don't ever grab the person who is in contact with that electricity, because then it could flow through you as well. You could use a stick or wooden object to try to knock them off. The rule of thumb, when you are around somebody who is burned, and this is in the emergent phase, you have to stop the source of the burn. That's 101. The problem is, don't ever put yourself also in harm's way, because now you'll have 2 victims instead of 1. So make sure that you're maintaining your safety while you're trying to help the victim get removed from the burn. So you got the electrical burns. You can have a chemical burn where you have acid spilled on a person. And in a chemical burn where there's acid that is just peeling through the skin or the face or the eyes, the thing you need to do there as a nurse is just douse it with water as fast as you can. If it's some kind of a powder, like a fertilizer or something that is causing the skin burn, you might need to brush it off. Some of those powders, if you actually use water, it can activate it, so that would make it worse. But you can just brush that off. If it's a liquid thing, then just douse it with water and water and water and water, because you want to dilute it as much as possible. The thermal burns, like the patients who are frostbite, those you just need to warm up slowly. All of the burns are incredibly painful. The frostbitten person, their cells actually freeze and develop crystals in there. After you've removed the person from the initial source of the burn, the next thing that you want to do is stop the heat. You have to stop the heating process, or in the case of frostbite, you have to start rewarming. You do need to be careful that you don't cause extra damage. So in your frostbite person, you're not going to put those hands in scalding hot water, because now you're going to cause, a heat-related thermal burn. So you're just going to put them in lukewarm water to try to start bringing them back up to temperature. If your patient has been, in a fire or something and you've gotten them out of the fire, you don't want to put them in an ice bath or put ice right on that burn, because you could cause hypothermia or frostbite. So what you want to do is use cool things to stop the heat. When somebody is first coming out of a fire, you don't put ointments on them. Get their clothes off of them, because a lot of the clothes that we have now have polyester and things in them that could be melting. So you want to get the clothes off as quickly as you can, and get the area that's been burned, get it cooled down as fast as you can, and keep cool compressions on there. So if somebody's around, have them run and keep getting cool rags. If those clothes that you've removed from that patient are around, douse those in water and keep replacing them with cool water. And you don't put any ointments or creams on your patient right after the burn. I volunteer sometimes as a nurse at a camp in northern Michigan, and the infirmary is right next to the kitchen. And this was a couple of years ago. I'm working in the infirmary, and all of a sudden one of the cooks in the kitchen comes running in with one of her workers who had gotten splashed with hot oil. They were frying something, and it dropped, and all of this hot oil got all over her body. She immediately started getting blisters, which we'll talk about in a minute, super common. So I grabbed her and got her in the shower and just put her in a cold shower and just started showering her right away. Well, the cook that was standing there with her, was I don't know, she was probably 50 or 60 years old, and I'm sure back in the day that they just started slapping creams on everything. And she just kept saying, get the Silvadene cream, get the ointment on her, we get her out of the shower, we got to get the creams on her. Well, and it was really quite frustrating, because I'm trying to take care of this girl who has oil burns all over her, and this cook was just frantic that I wasn't getting these creams on her early enough. So here I am trying to manage this emergent situation, while at the same time I had this cook over here who I'm trying to teach that we don't put the creams on it right away. We have to stop the burns right away. We did finally end up getting her calmed down, and over the next week I spent every day changing this girl's dressings, because then we started putting Silvadene cream on her, because now she did have the blisters, and we're treating her for pain. So those are the kind of scenarios that you're going to be facing as a nurse. So those are the different kinds of burns. And the other things that you need to be aware of with your burn patients, and this can be in any of the burns, is that it can cause cardiac alteration. So your patient who has been in any kind of a burn, you need to watch them for dysrhythmias, because of a couple of reasons. There's massive fluid shifts. Your burn patients tend to get metabolically acidotic. They tend to be anemic because they're losing a lot of plasma, but they have high hematocrits, high hemoconcentration, because of massive fluid loss. Like they're losing plasma, but the red blood cells are there, so they are in a hypertonic state. So giving these patients lots of extra fluid is really important, and they almost always give lactated ringers. They found that normal saline tends to cause acidosis, and the patients already are acidotic, so they usually give lactated ringers and a ton of it. So the problem with giving somebody a ton of fluids, which you have to because they've lost so much fluids, is you're really hoping that their heart and lungs and kidneys can accommodate that, can accommodate all the fluids in addition to the fluid shifts. So those are all the things, and we're going to talk a little bit more about each one of those that you're going to be watching for in your patients who have burn injuries. The other thing that you watch for are fluid and electrolyte shifts. Remember back to our fluid and electrolyte lectures, the sodium is the major cation outside the cell. Potassium is the major cation inside the cell. Well, in burn patients, you lose a lot of that sodium, and then you have excess potassium because the potassium is still inside that cell. And so you can, and with all the fluid shifting as well, you can have massive fluid and electrolyte shifts, which if you'll go back to our fluid and electrolyte days, you know can have significant implications on pretty much every other organ in the body. So it becomes really important to monitor your patient's fluid and electrolyte status. Okay, now on page 1811, you will see down at the bottom they start talking about escharotomies and fasciotomies. I'm going to come back to that because escharotomies and fasciotomies, they might be necessary when the edema gets so significant that you need to relieve pressure. But I want to start with the edema, the emergency phase, because you're not going to be doing a fasciotomy or escharotomy in that emergent phase. And the emergent phase, they don't even start telling you about this until page 1814. So we're going to talk about that in a second. So skip that. Even though when I start talking about this, I want to come back because over on page 1812, there's a picture of an escharotomy and a fasciotomy, but that does not happen in the first 24 hours following a burn. So I'm going to come back to that one. So the other problem that you'll have, this is really important in your patients who have a lot of smoke inhalation. So obviously your frostbite patients are not going to have inhalation injuries, but your patient who may have been in a house fire and sucking in a lot of oxygen, smoke, could have inhalation injuries. And that's problematic because you get all the edema and swelling in the pulmonary spaces, and that becomes a humongous airway problem. So you're really worried about patients with smoke inhalation. The other thing that you worry about is your patients who have carbon monoxide poisoning. These are patients who, like some houses that have malfunctioning, while these are the ones that the patients are, the victims are sleeping and they never wake up because they have too much carbon monoxide in the house. Another classic one is people who try to commit suicide by sitting in a car in a closed garage. They'll turn the car on, and the emissions from the car, they're blowing out all this carbon dioxide, and then it depletes the oxygen content in the air, and then the patient's just sucking in all this carbon monoxide, and it replaces the oxygen content, and then the person just kind of falls asleep. The carbon monoxide poisoning classic is this cherry red face. So if you're taking care of a patient and they come in, they're having trouble breathing and their face is cherry red, they probably have carbon monoxide poisoning. They need really high levels of oxygen and humidified oxygen. So you'd put them on like 100% oxygen, humidified oxygen, if they don't have to be ventilated. Okay, so pulmonary alterations are huge in your burn patients. Kidney problems are big because the patients can be hemoconcentrated, dehydrated, and then you're throwing a ton of fluid at them. And so you're really hoping that they don't also have some kind of a kidney problem where they're unable to accommodate those extra fluids. Urine output is key. You've got to maintain a urine output of like 30 to 50 cc's an hour, and in some cases even higher, like in the electrical burns and stuff, you want that even higher to make sure that those kidneys are flushing really well. GI problems are huge. This is true with all of your patients who are undergoing stress or surgery or trauma like this. The gut tends to slow down peristalsis. The reason being, your gut is one of the non-essential organs, so when your body goes into stress, it will shunt blood to the vital organs, your brain, heart, lungs, kidneys, liver, and your gut and your skin, not so much. So peristalsis tends to slow down, so you can get a paralytic ileus, meaning part of the gut stops, so all the gas and the food that hits that just kind of sits there and stops. So then watch for bloating. The patient might start experiencing nausea and vomiting, so you might want to get your patient right away on stool softeners and fiber, and if possible getting them up walking around. The other problem is they're probably also on narcotics because pain I mean, burn injuries are so painful, they're probably also on a narcotic, and narcotics tend to decrease peristalsis and cause constipation, which compounds the problem. So you need to be very vigilant when you're taking care of these patients to also maintain a healthy gut. Another problem in burn patients is the breakdown in skin leads the patient wide open to bacterial infections, which is a huge problem in your burn patients. And the problem is you have normal bacteria on your skin. You've got good bacteria. It's called your normal flora. You've got bacteria in your GI tract. You've got bacteria in your skin. And most of it is good. The good bacteria, gets rid of the bad bacteria. Well, when this is broken down and broken open, oftentimes the patient's own normal flora will get into these wounds, and that's the thing that's causing infection. So even though you have to be very careful in your patient who has burns, that they're not exposed to excessive bacteria. So if somebody's sick, they can't come visit. Patients who do come visit should have a mask on and gowns and gloves when they're talking to them and near them, just to prevent the transmission of bacteria. But the other thing is when the patient is their dressings are being changed is another time when bacteria can get introduced to the patient. So back in the old days, when somebody had a really severe burn, they would put them in hydrotherapy tubs. So they'd put the whole patient down in a tub. It's kind of like a hot tub, like a whirlpool bath. But what they found is that they put the patient down in the bathtub, and the water would spin and churn, but it was just churning around the patient's own normal flora or any bacteria that was growing in the skin, and it was just redistributing bacteria everywhere. So now what most burn units do is they will shower the patient, or they will have hydrotherapy carts where if a patient is non-ambulatory, if they're not able to stand up, they will wheel them in a cart and shower them off so the water is not circulating, it's just running off. And if the patient is ambulatory, can get up, then they can actually go in the shower and wash off, and that's the most effective way to prevent the transmission of bacteria or the patient's own normal flora. Thermoregulatory alterations are huge because, like I said earlier, the skin is so has such an important role in maintaining body temperature. So that's why the units are hot, because the patients can't control their own body temperature. Okay, so now that's sort of an overview of burns. Now the next thing that's important to know is the different phases of burns. You have the emergent phase, the acute phase, and the rehabilitative phase. They tend to overlap. And there's a table 62.3, the phases of the burn care. You should know that. That's important. So let's talk a little bit about this emergent phase. So in the emergent phase, I already told you, get the patient away from the burn site, start cooling down the burn, maintain airway, that's the most important. And remember, breathing and airway are two different things. Airway, the structures have to be open. So from your alveoli to, up to the trachea and the mouth, those all have to be open. That's airway. Breathing is the actual exchange of oxygen and carbon dioxide. That also needs to be occurring. That's 101, safety 101. Get their airway opened up. Not every patient needs to be ventilated. Those are just your really severe cases. Most of your patients are not going to need to be on a ventilator, but they probably will need some kind of supportive oxygen. Your patients who do have major head and neck burns, yeah, they're probably going to need to be intubated, which is not a bad idea because, and this is true in any kind of trauma, the swelling is going to be the worst in the first 24 to 72 hours. So the first 1 to 3 days following any injury is when the inflammation is going to be worse. So that's when you really need to be vigilant about, the anti-inflammatories, keeping the head of the bed up, doing anything that you can to prevent excessive edema and keep the patient breathing. Okay. I like the chart on page 1815, chart 62.4, that this tells you the emergency procedures, and I kind of touched on almost all of them already, this is what you do during the emergent resuscitative phase. We're just trying to save that patient's life at this point, or minimize the burn. If it's not a life-threatening burn, we're going to try to minimize it if it's, you know, more localized. Oh, here it is. This is what I was trying to find earlier. On page 1815, this is when, once you figure out the total body surface area that has been burned using the rule of nines, then you have to figure out how much fluid you're going to give that patient. And this part is important. This is the part you'll probably get tested on. When somebody is burned, they need a ton of fluids to replace the fluids that have been lost. And by a ton, I'm talking like, you know, 500, 600, 700, 1,000 cc's an hour. So the way that you figure it out is it's a formula right on the very top of page 1815, and it's 2 milliliters of LR, lactated ringers, times the patient's weight in kilograms. So if they come in pounds, you're going to have to multiply by 2.2. And then you multiply that by the percentage of the total body surface that has been damaged. And if you read the McCoy book, which hopefully you have, the Still on Fire book, he was burned like over 90% of his body. So you would take the 2 mLs of lactated ringer, time the patient's weight in kilograms. So let's say he was 200 pounds, so like 400, like let's say 450 kilograms, then you would multiply that by 90. And that's going to give you the total amount, and I'll do this in class, I won't do it right now because of the video that's running, but that's the total amount of fluid that that person needs in the first 24-hour period. And then what you do is you divide it in half. So just for math's sake, let's say it comes out to 10,000 cc's. So you're going to give the first half in the first 8 hours. So that's 5,000 cc's in the first 8 hours. And the key here is at the time of the injury, not the time they arrived at the hospital. So if they got injured at noon and they arrived at the hospital at 2, now you have a 2-hour lapse there. So you've got to make up for that time. So now you're going to multiply it by 6 instead of 8 when you're trying to figure out how much cc's per hour, and I'll explain this more in class. And so then if you've got 5,000 cc's that goes in that first, the first 8 hours, then over the next 16 hours, you take that and divide it again. So you take 5,000, divide it again. So in the next 8 hours, you're going to get 2,500, and then in the third 8 hours, you're going to get another 2,500 cc's of fluid. I know that's confusing. I kind of need a whiteboard here to show you what I'm talking about, but I'll show you in class how that works. It's not super complicated. Okay, so that's how they figure out how to give fluids. So then that emergent phase, that's going to last, you know, about 2 to 3 days, depending on the severity of the burn. And then after you get, now you know your patient is at least out of the woods, so to speak. So that they're stabilized. You're starting to kind of manage the fluid shifting. You know their airway is okay. Now they're going to move into the acute or intermediate phase. And this is the phase where the fluids start getting all wacky. So during this acute phase is when you're going to see some pulmonary edema. You're going to see a lot of fluid shifting. It is essential during this phase that you are being vigilant in hand washing, covering your mouth, making sure that you're preventing wound infection. Wound cleaning is huge. Sometimes one wound dressing change will take several hours. There's a lot of really good dressings out now, and a lot of them have silver in them. There's like silver infused dressings. I think I have some here. I'll try to remember to bring them to class to show you what they look like. They look like big sheets of silver. They're kind of expensive, but they work really well. Silvadene ointment, Silvadene cream is another one that we use a lot in the burn patients. And then as those wounds are starting to heal, this is when we start doing wound debridement, because you need to get rid of the tissue that is necrotic and dead, because that can lead to more infection, and you want to promote healthy wounds, and epithelial stimulation and blood and oxygen coming into those wounds. And that starts occurring here. Also during this phase, because the swelling may get so much, now we may have to do an eschorotomy or fasciotomy. So now I want to go back over to page, what page should I have that on? I told you about it. Page 1812. So what happens sometimes in these bad burns, especially if the skin is still intact, is that the skin swells up really fast because of third spacing, because the fluid will shift out of the intervascular spaces, they shift into the interstitial spaces, and massive edema can start occurring. When massive edema occurs very quickly, the skin cannot stretch to accommodate that. Like for example, in a woman who gets pregnant, her skin can stretch a ton. Or in a person who is obese, their skin stretches a ton, but it's over a long period of time. When the skin has to stretch really fast, really quickly, it can't accommodate that. So what happens is the pressure starts going back inside, causing compartment syndrome. And what it'll do is almost acts like a vice, and all of the blood vessels and the nerves and the bones and everything that's in there starts getting compressed and pressurized. And you'll see that because the patient will start having decreased pulses, numbness, tingling, paresthesias in their hand, and you know that that swelling is getting so much now that it's causing compartment syndrome, and the patient may have to have, or the other thing that could be causing it is scar tissue. So once the scar tissue starts laying down and starts rebuilding, if that starts compressing in so tight, remember I told you that scarring is very tight and fibrous. If it's so tight that now it's not allowing any stretching, it will also cause compartment syndrome. So the scarring that lays down, if you have to open that up, it's called an eschorotomy. Or if you just have to cut the skin down to the fascia, that's called a fasciotomy. And what that does is it just relieves pressure. And so you can see a picture of it. Figure 62.5 is an eschorotomy. They're just cutting through eschar. They're cutting through scarring to allow more pressure in that forearm. And in figure 62.6, now they've gone all the way down to the fascia to accommodate more pressure. More swelling. And so, but once the swelling and everything goes down, they can reclose that up. But again, infection is huge at this point, as is pain. That's very discomforting. So anyways, you can see both of those. The one at the bottom is a swelling issue. The one at the top is a scarring issue. So those are some things that the patient may have to go through if they're starting to be unable to accommodate all of the swelling. Okay, so then once the wound starts healing, and you've debrided it, and you've done your eschorotomies or fasciotomies, you may have to start doing some wound grafting if the skin has been so badly burned and that it has to be replaced. So if you've got huge chunks of skin that's just gone, that it won't regrow on its own. So we do have ways now that we can graft in skin, a lot of actually quite remarkable ways. There are autografts where they take a piece of healthy skin. So if a patient is just like, if their upper body's burned, they can take skin from the legs and they run it through like this harvester thing, and it kind of, so you have like a piece of skin like this, and it runs it through this machine that's almost makes it has holes in it that would be like a kind of like a chain link fence. So there's like, or like a checkerboard, how they're, they're kind of, they just make holes in opposite directions. And then what it does is it expands the skin, and then they can put that skin back on the patient, and then all those areas that have holes, it'll fill in, just like a regular, like if you get a little scar or something, the skin will form back together. So that's how a graft works. There's autografts where they can take it right from the patient. And once again, they don't have a good picture in here, but I'll show you a picture of a harvester. And they just take the top layer of the epidermis off, so there's not blood in it. It's, it doesn't hurt a ton. It's like almost like a sunburn. And then they can put it back on the patient. And these pictures you see on page 1824, like figure 62.7 and 62.8, both of those patients have grafts on them, and the grafts are now filling in and to become regular skin. They do have another way now where they will culture cells, especially patients who have been burned so severely they don't have a spot that they can give to grow, or to make those the bigger pieces of skin. So they will take cells from the skin and they'll send it to a lab and they culture it. They will regrow cells in the lab, and then after about 3 days they'll send it back and then put it on the patient, and that also will start to regrow. So just be aware that there's some, they often, in bad burns, they'll often try the grafts. There are a lot of new dressings out, the biosynthetic dressings now. Take a look at that on figure 6210, and it describes it there on page 1825. Those are kind of up and coming and really useful as the patient is healing. They help prevent infection. They help they allow the skin to heal on its own. So those are some good advances in burn technology. So read through the rest of it. Read through the nursing management during the acute phase. Also during the acute phase, you can't underestimate the emotional component, because at this point, and it really kind of moves into the rehabilitative phase, which is we're starting that on 1829. This is when the patient now, they're out of danger. The fluid and electrolyte status has stabilized. We know that we're going to be able to save the victim, but now all of a sudden we have to deal with scarring, and there are some ways to prevent scarring. One, compression, like they make the compression like hand molds or like face mold, they put on the face, and that helps mold the skin. It helps keep scarring down. The other thing you want to do with your patients is keep them in as much of a normal position as possible. So when they're sleeping, their fingers should be extended, their elbows should be extended. You don't want them up on pillows because you don't want scarring to form in here. So you just have them lay flat, and a lot of therapy. You want them moving, you want them stretching, because you don't want contractures, which are very common after burns. You don't want those contractures to develop. So as soon as possible, as painful as it is, you want to keep that patient moving, and when they're sleeping, you want to keep them as extended as possible. Just because you want to prevent the contractures. Psychological support now becomes huge, especially if it's a face injury, because it can be often debilitating. And these patients who have suffered severe burns are now extremely disfigured, and that creates an incredible emotional toll on a person. Read the McCoy book and you'll know what I'm talking about, because he was burned over 90% of his body. Much of it was his head. Okay, so all right, now I'm on page 1830, where we're talking about abnormal wound healing. It's kind of like I talked about earlier with the keloids and the that are starting. So okay, so that's about it with burns. That'll do it for this week. I think that's it. If I forgot to tell you something, I'll tell you in class, and call me if you need me. Okay, see ya.